Thank you very much for that kind introduction. It's really a pleasure to be here to talk to you about the use of echocardiography in the management of temporary mechanical circulatory support. I don't have any relevant disclosures, but I do want to acknowledge that some of the images I'm providing are courtesy of J&J MedTech Abiomed, and these are the manufacturers of the Impella device. My objectives are as follows. I want to provide a brief overview of the types of common temporary mechanical circulatory support, or MCS, options available. We're going to focus on VA ECMO, or veno-arterial extracorporeal membrane oxygenation, as well as temporary percutaneous left ventricular assist devices, namely the Impella CP and Impella 5.5, due to their wide availability and use. Next, we'll discuss how echo is used to guide the placement and weaning of VA ECMO and how it can help evaluate common challenges at the bedside. And lastly, we'll discuss how echo can evaluate and troubleshoot common scenarios that arise with temporary percutaneous left ventricular assist devices, specifically the two Impellas that are currently being used in Canada. So what is VA ECMO and why do we use it? On the left, I'm showing a very simple schematic, and what it tells you is that this is a circuit that drains blood from the right atrium, delivers it to a centrifugal pump, which is then transitioned to an oxygenator, and this blood is oxygenated and returned to the aorta. For the most part, due to its speed and readily available use in many, many centers worldwide, I'm going to focus on peripheral VA ECMO. So on the right, you see a schematic here demonstrating that it is usually the femoral artery and veins that are cannulated, where blood is being drained, as I said, from the right atrium, delivered to a centrifugal pump, oxygenated, and then returned to the descending aorta. So keep this in mind as we're discussing the echo images. Well, what's the point of VA ECMO? This figure kind of illustrates everything in a nutshell. So on the left, you see that the reason we use VA ECMO is to support patients with refractory cardiogenic shock. It's been used in acute myocardial infarction. We commonly have good outcomes with situations such as myocarditis or graft failure after heart transplantation due to the reversibility of these conditions. But it can be used for other chronic heart failure situations, such as a chronic cardiomyopathy, pulmonary embolism with RV failure, chronic RV failure, and post-cardiotomy or other indications. We do often have discussions around refractory ventricular arrhythmias as being an indication, and as well as cardiac arrest, the latter being somewhat controversial. But the whole point of this, as this figure shows, is that VA ECMO is a bridge to something. It is hopefully a bridge to recovery. That would be often the best outcome, but sometimes it is a bridge to transplantation. It may be a bridge to durable mechanical circulatory support, and sometimes it's just a bridge to make a decision because due to the rapidity of decline in the patient, you are offering them the support to then decide what's next. There are important contraindications to VA ECMO, and the one that I want to highlight, because it is relevant when you're assessing a patient, is aortic dissection. Aortic dissection is an absolute contraindication, and this is something that could be relatively straightforward to evaluate with echo, depending on the clinical circumstances. And we'll get to that in a minute. There are other absolute and relative contraindications, such as severe irreversible non-cardiac organ dysfunction, coagulopathies, or vascular access issues. When we're thinking about VA ECMO, this is probably the most important point to make when it comes to the physiology, because this will come back to help us understand how echo can be used in these cases. So VA ECMO delivers retrograde aortic flow. And what that means for your right ventricle is that as the flow through the circuit increases, your right ventricular end diastolic volume and your right ventricular stroke volume are going to decrease. And assuming that RV contractility, of course, is unchanged during this time frame. And that's what the pressure volume loop on the left shows. On the left side, though, the consequences for the left ventricle is that as flow increases, the LV afterload and the arterial pressure, sorry, the LV afterload goes way up, and that's what the pressure volume curve shows at the bottom on the right. But the arterial pressure and the pulse pressure will actually drop. As a result, you have actually a shorter stroke volume for the left ventricle, and the aortic valve opening also shortens. This is very, as I said, highly relevant when we're thinking about consequences of being on VA ECMO. And this slide just sort of further demonstrates that point hemodynamically. So on the left, as you see at the top pink, the LV volume will increase as the flows increase. The pressure in the aorta and in the left atrium will increase as the flows increase because of the retrograde aortic flow. So that's increased afterload. And because you're draining from the right atrium, the right atrial pressures will actually drop as you increase your ECMO flows. So ECMO is one form of temporary mechanical circulatory support. Another important one that we're increasingly seeing in Ontario, Canada, and worldwide are percutaneous left ventricular assist devices. And the two that I'm going to focus on, and I'll explain why I'm focusing on these two in a minute, are the Impella CP and on the Impella 5.5. It's important to know the difference between these devices because they look different on echo. So on the left, you see the Impella CP, and on the right is the Impella 5.5. These are both left-sided support systems, meaning they drain blood from the left ventricle and deliver it into the aorta. The Impella CP is inserted percutaneously, usually via a femoral artery or sometimes an axillary artery. Whereas the Impella 5.5, it actually requires a surgical cut down of the axillary artery or directly into the ascending aorta. They're different in sizes, and as a result of that, the flow from the Impella CP is less at about 3.7 liters per minute maximum, whereas the Impella 5.5 can deliver, as the name suggests, 5.5 liters of flow. The key thing, and I'm using my mouse to highlight this, is that the Impella CP has this pigtail with a teardrop inlet. And that's very different than the Impella 5.5, which does not have this pigtail. This will become very relevant when we look at images. And why do we use these devices? Well, I think over the past decade or so, the indications have evolved, studies and including randomized trials have evolved. And so this is sort of the latest recommendations across major cardiology societies. So for example, the American College of Cardiology believes that in selected patients with STEMI and severe or refractory cardiogenic shock, insertion of one of these devices is reasonable, recognizing that the level of evidence is sort of a class 2B. The Europeans have a similar thought process when it comes to short-term mechanical circulatory support, both for cardiogenic shock, which they place a slightly higher recommendation, but both are just consensus expert in terms of their overall level. The Canadian Cardiovascular Society hasn't really updated our recommendations recently. This is from the 2017 guidelines, and basically they suggest that temporary MCS can be offered for the opportunity to evaluate long-term options. So that's sort of why we use these devices. For the Impella, this is just a quick look at the console. Most of the time, the purposes of understanding this when you're thinking about it from the echo perspective is that if there's a change in either the aortic placement signal or the LV placement signal, those are the red and white curves at the top. or the systemic flow, which is demonstrated here at the bottom left, that may lead you to think about why this is happening and how echo can help. The flow control is on the right side, and that's what you see here. It's labeled P7 in this case. So why am I talking about temporary MCS? I think it's important to recognize that while this is very common worldwide, we are increasingly seeing its use, ECMO in particular in Canada. This is from the ELSO, which is an organization for extracorporeal support. And as you can see, while currently the major centers that offer ECMO, and I should say the caveat here is that these are centers that report to ELSO. As might be expected, concentrated in parts of Ontario, Quebec, and large centers in the West Coast, such as Edmonton, Vancouver. But the use of ECMO and the availability of ECMO is growing. And when I was looking at data for Canada, this came up from Thunder Bay Regional Health Center, suggesting that ECMO therapy may be available there. And this is the case for many centers, including Sudbury, for example, just to kind of focus on the Canadian and provincial landscape. What about temporary left ventricular assist devices? Well, this has been exploding for more than a decade. This just shows you the trend of Impella use in patients undergoing PCI, requiring mechanical circulatory support. And it is only up to 2016, this from this particular paper. But if you look at trends from 2019 to 2024, it's becoming even more obvious that Impella use is growing. So Impella use is in the green on the left of this figure, with a sizable increase from 2023, 2024, and ECMO is in the sort of salmon pink color here, also increasing in use in the more recent era. And as I said, the reason I'm focusing on the Impella 5.5 and Impella CP is that, in particular, the Impella 5.5 is growing in its use across the world, across the United States, and also with increased availability in Canada. So next, we'll talk a little bit about how to use echo to guide the placement and weaning of VA ECMO and how we can evaluate common challenges at the bedside. So the truth is, echo is useful at all stages in VA ECMO management. So first of all, pre-implantation of VA ECMO, I alluded to one absolute contraindication, and that's aortic dissection. However, an echo can help understand the etiology of the cardiogenic shock if it's not clear. From this paper, they describe how you can establish hemodynamic parameters or evaluate filling pressures and cardiac output, before you have hemodynamic parameters using echo with data from your VTI or from the filling pressures on the left and right side, respectively. Pre-implantation of VA ECMO, it's also important to establish whether there's a pericardial effusion, whether there's severe aortic regurgitation, which may make ECMO less effective, and whether there is significant atheromatous disease, which may also increase the risk of complications such as stroke or embolism. So the time at which ECMO is implanted, particularly the percutaneous approach, echo is very useful. At implantation, echo can be used to assess correct placement of guide wires. In this figure, what you see, and I'll show you some clips in a second, you see the IVC and you see the drainage cannula that's going to go to the right atrium visualized very well. So ECMO implantation is a percutaneous approach. It's used using the Seldinger technique. Some people find it's very helpful to have a biplane image with a 3D probe because you can really nicely follow wires during implantation, particularly if there's some uncertainty about placement. As I mentioned, for peripheral cannulation, most commonly we're using the femoral vein, and that's referred to the drainage cannula, and the femoral artery, which is the return cannula. Uh, the drainage cannula should be ideally placed at the SVC-RA junction, and this is a transesophageal echo. And at the top right, you see the cannula very nicely right where the SVC and RA junction are. What you don't want to see, and that's the figure at the bottom, is that the drainage cannula should not abut the interatrial septum. It shouldn't really interfere or interact with the tricuspid valve or the right atrial wall. The best views to get for this part of the implantation are the subcostal views of from your IVC on a transthoracic, which is often the case because these patients don't necessarily need to be intubated if their oxygenation and mentation is adequate. So we do often, if we're cannulating peripherally a patient who's awake, use our transthoracic echo views, particularly the subcostal ones. However, if there is the opportunity to use a TEE, the mid-esophageal bicable view is your best look at the drainage cannula. The return cannula, or the blood that is oxygenated and returned back to the aorta, is often placed via the peripherally via the femoral artery. And you may be able to visualize the guide wire in the descending aorta through implantation, but as you see in this figure here, the return cannula actually is not usually visualized on echo in the descending aorta position. So usually in these situations, the guidance of ECMO implantation focuses on the drainage rather than return cannula. So after implantation of VA ECMO, the truth is echo is useful on a daily basis to reassess and to evaluate for the following. You want to ensure that there's lack of an intracardiac thrombus that has developed. You may see blood stasis or spontaneous echo contrast, which is concerning because it could lead to the former. The aortic valve should be opening with every beat, and you may also want to evaluate for adequate drainage of the right ventricle and left ventricle and look for findings such as more TR and MR than you started with. A pericardial effusion is something that can be detected easily with an echo, and it may become clinically relevant, and I'll get to that in a second. And lastly, the early diagnosis of myocardial recovery is sometimes most apparent on echo. I should comment here, and I'll get to it at the end as well, that contrast use is safe in ECMO, but there's one caveat. If this is a support system you're not familiar with and you are going to use a contrast enhancing agent to improve image quality, you should have a perfusionist or a physician at the bedside who can just silence the bubble detector alarm that is triggered when the contrast is injected. It's momentary. It is not of consequence to the patient or to the circuit. So, as I was saying, you can get a lot of implications or information from your echo, and I want to focus for a minute on the implications of a closed aortic valve. And so that's what this figure shows, is that the aortic valve is closed on a VA ECMO circuit, which should not be the case usually. And the problem with this is that blood will gradually accumulate within the left ventricle. You'll see increased distension, increased wall stress, and you may see thrombus formation either in the left ventricle or, as you see on the right here, just at the level of the aortic valve and ascending aorta. The top figure I've just highlighted demonstrates how quickly and how dramatically LV thrombus can form inside the LV when someone's on ECMO if they don't have adequate ejection, allowing for venous stasis, particularly when anticoagulation is not therapeutic. Another implication of a closed aortic valve in VA ECMO is if there is no ejection of blood through the aortic valve and the LV becomes increasingly distended, your patient may end up having increasing pulmonary edema, which is also an unwanted and important complication of the circuit that we try to avoid. So all of this can be really nicely assessed on echo. So what can you do to fix this? Well, echo helps here as well, and I'll tell you how in a minute. So here are some things you can do, and for the sake of this talk, I want to focus on the fact that while there are medical and specifically medications and changes to the circuit that can help, you may need to consider directly draining the left atrium with an atrial septostomy, an LA vent. That's a common procedure used at our center. Or use an Impella to decompress the left ventricle where aortic valve opening no longer becomes an issue. And sometimes in very specific situations, surgical venting is required. And all of this is usually supported with echo visualization. So here is a still image, oops, of a, actually not a still image, it is a clip that I got of a patient who has a left atrial septostomy, and through that septostomy is a drainage cannula. The arrow points to the left atrium, and the drainage cannula is placed through a femoral vein, usually at our center. The nice thing is as a lot of these images, so this is the parasternal short axis view, a lot of these images, if your patient has windows, can be acquired with the transthoracic study to demonstrate the appropriate positioning of these additional cannulas. However, if your patient is intubated or requires a TEE, as you can see here, you have this sort of mid-esophageal view demonstrating a cannula traversing the right atrium. There's the interatrial septum into the left atrium. And the purposes of this is, again, to vent or drain blood from the left side to prevent pulmonary edema and clot formation in a patient on peripheral VA ECMO. So another helpful use of echo is pericardial effusions in patients on VA ECMO. To be honest, this is case studies, and most of the time you have to look at clinical clues to determine whether a pericardial effusion is important to a patient on ECMO. Things like lower flows despite the same speed, loss of arterial pulsatility, or suddenly requiring more pressors, suddenly loss of urine output. These can be clues. The presence of a pericardial effusion is helpful. And to be honest, a lot of the traditional echo parameters, because you have a continuous circuit draining blood from the right atrium and returning it to the aorta, many of the common parameters we think about are not really applicable when a patient is on VA ECMO. And so in case studies, case reports, diastolic collapse of the RV seems to be appreciated, but it's usually the combination of clinical clues, the presence of a pericardial effusion, particularly if it wasn't there before. This is where pre-implantation echo is extremely helpful, because if it wasn't there before and now you have a large pericardial effusion and clinical changes, then you may actually be looking to perform a pericardiocentesis. The last and probably best studied use of echo for VA ECMO is the use of echo for ECMO weaning. What do I mean by that? What I mean is that you can actually slowly come down on the flow from your ECMO circuit. Thereby, you are increasing the preload to the left ventricle, you're reducing the afterload, and you're loading your right ventricle. And the point of all of this is to see what happens and whether or not you can support your separate your patient from the ECMO circuit. So the stepwise reduction in ECMO flows with the evaluation of hemodynamic and echocardiographic parameters has been well described. What I'm showing you here is actually it's a great resource. It's the 2024 recommendations from the American Society of Echo for LVADs and temporary MCS. And for each ECMO flow reduction, what you want to establish is what's the LV size and function? Has the LV gotten larger or has the function improved or deteriorated? The LVOT VTI as a marker of cardiac output is well established in the ECMO literature, and more than 10 centimeters is felt to be indicative of success. You can look at the tissue Doppler of the mitral valve, the lateral E velocity, RV size and function, TAPSE more than 10 millimeters, and an RV S prime that is improved as well is helpful. You can look at S prime to RVSP, particularly when the flows on your circuit are very low, and the RV function. I think the key thing when you're performing an ECMO wean using echo, and something that a lot of our sonographers and fellows do, is they create tables and incorporate those tables as the flows change into their report, thereby making it easy for both the reader and the clinician at the bedside if they hadn't been supervising the ECMO wean to understand what happened. Here is our weaning protocol, and what I want to really highlight is after any confounding clinical factors are absent, after you're confident that the end organ function is good, anticoagulation targets are met, the next big step is, as I said, echo is really important here, is assessing the right and left ventricle recovery with echo. And in our program, we focus a lot on on the LVEF, RVEF, but also on other parameters such as the LVOT, VTI, and the tissue Doppler. And so this was published a few years ago, but it's not the only protocol available. There are actually many, and almost all of them have, if not some, echo parameters that are used to define a successful wean. I've highlighted the one at the bottom mostly because I think the right ventricle, if there's going to be a problem that you didn't anticipate, it's usually the right ventricle that fails when you're trying to come off support. And many of the parameters that we use, apart from, your mean arterial pressure, blood pressure, are based on echo findings, and they include the development of severe TR, if the RV and diastolic dimensions start to increase above 35 millimeter, and your TAPSE drops above 1.5. This was suggested in this study of several years ago, that these are very helpful markers for determining whether the RV will tolerate separation from this circuit. So that's sort of a whirlwind, but really sort of meant to highlight how useful echo is when you have a patient before, during, and potentially after a VA ECMO implantation. Next, in the next 15-20 minutes, I want to discuss how we can use echo to evaluate and troubleshoot common scenarios that arise with temporary percutaneous left ventricular assist devices. And as I said at the beginning, the focus of this talk, mostly because of this is what we see, is on Impella CP and Impella 5.5. This is a very commonly used and form of percutaneous left ventricular assist device. So as with ECMO, echo can be used in the pre-implantation stage. And I would say that it's very, very important for Impella because there are certain considerations that have to be reviewed before this is implanted. And one of the most important one is the presence of a LV thrombus. And you see that in the figure on the right. An LV thrombus would be an absolute contraindication to insertion of one of these devices due to the risk of embolization and stroke. Other important considerations are the size of the LV. Sometimes this matters. If the cavity is very small, and usually small. This may not be a situation where the Impella may work well simply due to suction events and placement issues. And lastly, when it comes to pre-implantation, another very important red flag is the assessment for RV dysfunction. If you have a patient with biventricular dysfunction and the RV doesn't work very well by echo, for example, then your patient may not benefit from isolated temporary left ventricular support. They may need both ventricles supported. Other important considerations include valvular abnormalities, particularly mechanical prosthetic valves and severe aortic stenosis. And similarly to ECMO, aortic dissection is a contraindication. Cardiac tamponade is not necessarily a contraindication, but it may explain why your patient's in shock. And also, as I said earlier, knowing whether there's an effusion before you start is helpful to understanding if one develops after and how to manage that. So how do we identify these devices on echo? So remember I said that they look different. So that's kind of an important thing to remember. They look different if you were to view them in your hands. So the recommended views are the peristernal long axis from a transthoracic, and on the transesophageal, it would be the mid-esophageal long axis view that is recommended. And the bottom left here shows the Impella CP, and as you can see, I've highlighted here that this is your Impella cannula. There's the inlet area. There's always this artifact or visualization of the teardrop, and you'll see a pigtail. And this is very different. And understanding that this Impella CP appears this way is important because it's different from the Impella 5.5. The distance for the Impella cannula should be about 3.5 centimeters from the aortic valve leaflets to the inflow cage. Whereas for the Impella 5.5, which is on the right, as you see, there is no teardrop or pigtail. What there is a cannula, and that cannula should be about 5 centimeters from the aortic valve leaflets to the inflow cage. So once again, the correct placement of an Impella CP, this is an image. You should not see any rocking or swinging. The inlet should be free floating. It should be about mid-ventricle, 3.5 centimeters from the aortic valve. The pigtail and inlet should be free of the mitral valve apparatus, and this is particularly clinically relevant. And the outlet should be positioned above the aortic valve and should not be obstructed. Similarly, when you look at the Impella 5.5, this is on transesophageal echo. There shouldn't be rocking or swinging. There should be a free-floating inlet, free of the mitral valve apparatus, 5 centimeters from the aortic valve. The other important point to make is that there's this bend. I don't know if it can be well appreciated. If you look at a lot of these, and I'll show some that are malpositioned, the bend on the cannula should be at the level of the aortic valve, and the outlet should be positioned above the aortic valve and unobstructed. So when you're looking at an Impella 5.5 on TEE or on TTE, if you were to color Doppler the cannula, you'll notice this mosaic artifact. It's just an artifact generated by the rotor neighboring the outlet, and here you see it in the mid-esophageal view. The transgastric view, if you're stuck for whatever reason and imaging of the Impella is difficult, you can actually go to your transgastric views to visualize the position. The yellow arrow shows you here the cannula, and this distance is a little bit under 5 centimeters, but if it's acceptable and meets all the other parameters, may be okay for this particular patient. So when should we use echo to assess Impella position? The truth is, prior to and during placement, you have to check for an LV thrombus. That's a must. You do want to know the degree of stenosis or regurgitation across that aortic valve. I think it's always important to take another look at when a patient's being transferred from wherever they got this, whether it's an OR or a lab, to the CCU. And probably the most important is if there's a change in patient status, there's no harm to looking with your echo to understand what's going on, because it may be that the catheter has migrated. In clinical situations where there's been a defib or CPR, you'd want to understand that as well. If there's presence of hematuria or evidence of hemolysis, that's relevant. And then, as I showed you on that console, if you start noticing suction alarms or lower than expected flow, despite adequate preload, this may be a situation that you need to look at that right ventricle or understand what's happening with your Impella positioning. And lastly, similar to ECMO, you want to assess the readiness to wean the device. And so echo is useful there. So really during all aspects of patient care is echo important. So normal positioning of an Impella CP on echo is on the left. As you can tell, this cannula on the right, the Impella CPU is actually positioned a bit too deep. This may not be apparent without echo, or it may become apparent when the patient develops clinical signs of hemolysis. So that's why daily echoes to reassess positioning are important. For the Impella 5.5, optimal positioning, this is from a peristernal long axis view, is as we discussed, 5 centimeters. This one is just far too deep. It's over 6 centimeters into the LV, and if it isn't causing problems right away, it will and should be pulled back. On the right, when the Impella is too shallow, it may not be effective, or it may get caught in the mitral valve apparatus, and I'll show you a nice example of this in a minute. And then, as I was saying, the bend on the cannula should be such that it's at the level of the aortic valve. And in this particular case, when you compare this lower right image to the upper left, you can tell that this device is inverted. The cartoon illustration is even more helpful because you can tell here this is the peristernal long axis on transthoracic, that the bend and the tip should be sort of mid ventricle, and here it's inverted and really not in the correct positioning. Complications with Impella detected on echo include RV failure. I think this is an important one. Worsening aortic regurgitation, worsening mitral regurgitation, and hemolysis. This is a patient who had worsening mitral valve regurgitation, and I'll show the color Doppler images in a second. What's kind of clear here is that the Impella is actually too deep, and when color Doppler flow is added, you can see, and you shouldn't see this with the support system that's draining the left ventricle. It should decompress the left ventricle, and you shouldn't see this degree of MR. And if it's new, you want to ask yourself, well, why? So in this particular case, the reason was the Impella was just a bit too deep, and the creating a suction event. Oh, not sure what happened there. That was significantly worsening the MR. When it was pulled back, you can see that there's been a significant improvement in the reduction in the mitral regurgitation. So this is a very nice, real example of how malpositioned Impellas can create clinical consequences that can be corrected with visualization with echo and then subsequent repositioning. As discussed with both ECMO and left-sided support systems that are temporary, echo is very helpful to assess for readiness to wean the device. So this is a patient who had myocarditis. This first image is of them on VA ECMO because they were in Sky Stage D, cardiogenic shock. As a result of this, they were placed on ECMO. They had sufficient recovery such that they were transitioned to an isolated LV support system. And as you can see between these two pictures here is on echo, what became increasingly apparent before it was apparent otherwise was that the LV function had recovered. And this allowed, similar to what we do with ECMO, to decrease the flows of our Impella, thereby allowing us to evaluate native LV function and readiness to wean. And in this particular case, it was a good story because the patient recovered. So my final couple of slides are once again a plug for a really nice resource from the American Society of Echo, which discusses some key points. And I've kind of gone over this in this talk, but truth is, echo is very useful for temporary MCS to assess volume status, catheter positioning, repositioning, worsening RV function when you're on isolated LV support, such as an Impella. It may be very helpful when you have low flows or other clinical circumstances that you don't understand, and understanding them better with echo images to interrogate where the cannulas are, whether there's a pericardial effusion is necessary. As shown to you while on VA ECMO support, it's very important to look for blood stasis, thrombus formation, the presence and severity of MR, because these are clinically impactful findings. You can use POCUS, so surface studies for sure, to detect Impella device positioning and aortic valve opening and to rule out device malfunction. Ultrasound enhancing agents can be used in temporary MCS. And while the American Society of Echo is a little bit more cautious in that they shouldn't be used in ECMO devices, but the caveat is, as I said, unless under the supervision of experienced perfusionists and clinicians, because you will very transiently cause an air bubble alarm. But when using a judicious amount of ultrasound enhancing agent, we have not seen device malfunction at our center. So the bottom line is that temporary mechanical circulatory support devices are increasingly in use and are increasingly available in Canada, in North America, and globally. And that echo is a tool to support clinical decision makings all the way from pre-implantation to assessment for myocardial recovery or whatever the next steps might be for the patient. So that's the end of my presentation. I thank you for your attention and time. It's been a pleasure talking to you today.